Hi, everyone. Welcome back to the Insights podcast. I'm here with Salia, and we're going to do another 10 to 15-minute update about things that you can bring to the bedside for neurologic emergencies. As a reminder, all of our content comes from the on-call chapters in the Neurocritical Care website. So we really invite you to go to neurocriticalcare.org and check out the content there under the educational resources. As another reminder, we are so grateful for the sponsors of the podcast, Biogen and Cerevel. And now a word from our sponsor.
Founded in 1978, Biogen is a leading global biotechnology company that has pioneered multiple breakthrough innovations, including a broad portfolio of medicines to treat multiple sclerosis, the first approved treatment for spinal muscular atrophy, and 2 co-developed treatments to address a defining pathology of Alzheimer's disease. Biogen is advancing a pipeline of potential novel therapies across neurology, neuropsychiatry, specialized immunology, and rare diseases, and remains acutely focused on its purpose of serving humanity through science while advancing a healthier, more sustainable, and equitable world.
All right. Hi, Casey. It's good to be here and talk about ICP crisis. I know that we promised this to our audience, so it's really exciting to be back and talk about this really fun topic, but also really essential to neurocritical care management of our patients. So to start with, I think we're going to do 2 different discussions. One is going to focus on diagnostic piece of this. How do we manage or how do we diagnose ICP and what do we consider? And then how do we manage these patients and pharmacological management, which I'm really excited to talk about. So, Casey, when do you consider ICP elevation in your patients?
Yeah, this can be tricky. I mean, I think there are certain ones that you walk into the room and you see that a patient has a blown pupil and they're appended, and you're like, well, that's a no-brainer. They probably have some horrible ICP crisis going on. But I think most of our patients who have elevated intracranial pressure, and they're becoming more and more somnolent. And, the problem with that in the neuro patient population is that there can be a lot of reasons why our patients are sleepy. And one of the things that I think is really important to tease out is using the neuroimaging to sort of guide, does this person have risk factors for having an elevated ICP? Things that cause damage to the brainstem, things that cause damage to the thalami, things that result in bilateral cerebral hemisphere dysfunction, all of those things can make you sleepy. So what we're looking for, usually with our screening head CT when someone comes in the door, is does this person have evidence of a big mass lesion, something that's causing midline shift, maybe creeping herniation, transtentorial herniation, uncal herniation, a herniation syndrome because of a focal lesion. And that might be because, they have traumatic brain injury, they've had an intracranial hemorrhage, they have malignant ischemic cerebral edema after they've had a large middle MCA stroke. And then the problem could also be that they have global cerebral edema. And so that's, a thing that we can think about in our patients that have traumatic brain injury or encephalitis or even venous sinus thrombosis or anoxic injury. So there are so many neuropathologies that can result in increased intracranial pressure. The other thing that can cause increased intracranial pressure is if the patient has an accumulation of fluid in the brain, such as hydrocephalus. And I think of these as kind of 2 different baskets. So the patients that have a focal lesion, the patients who have global cerebral edema, and then the patients that have hydrocephalus. All of those things can cause elevated intracranial pressure, but they're managed a little bit differently. So I think the first thing that I'm doing when I walk in the room is trying to think about, is the patient sleepy or heading towards somnolence, comatose? And then do they have radiographic evidence of something that would mechanistically make sense to cause elevated intracranial pressure?
Let's say you are de-attending, taking care of this really sick patient with ICH, and then you realize that there is a significant midline shift. Can you walk us through how, again, you suspect ICP crisis and how you would go about your management of this patient?
Yeah, I think that's one of the most common things that we see. These patients who come in, they've got a giant bleed. And the bleed itself is not actually in one of the structures that would cause, just altered mental status. Let's say this is like mostly just in the basal ganglia, but it's causing some midline shift. It's causing compression and transentorial herniation that we can see on the head CT we just got. Like all other emergencies, like we're still starting with ABCs. The thing about this patient, you said they already have midline shift. They've got a big ICH. Already, I'm sort of thinking this patient is on the road to needing intubation. And so walking into the room for this sick patient, the first thing I assess are ways that we can optimize the patient just from like a bedside management thing, like sit the patient up. Then we have to think about, is their neck kinked to one side and that's preventing venous return? So again, just getting a neck midline and sitting the patient up, that can at least help temporize while you're trying to better assess what's going on. If the patient is agitated and having a lot of pain, that's also causing them to be combative. That can raise their blood pressure. We know that blood pressure and intracerebral pressure have injured patients a sort of linear relationship. And so that's another thing that we can just kind of address, trying to calm patients down, make sure they're not in pain, not agitated. All of those are just good things that we can do easily at the bedside before even having to initiate sort of higher tiers of increased intracranial pressure management. So that's really what I'm thinking as I walk in the rooms. Like, how can we optimize this patient while we're probably setting up to get the patient intubated? Intubation in patients with intracranial pressure issues really is a unique situation where you have to be very mindful of the patient's blood pressure, right? We know that you could worsen their bleed if their pressure is too high, but you could also cause perihematomal edema, and you could also cause, even low cerebral perfusion pressure if you let their blood pressure get too low. So I try to be like really hemodynamically neutral in that situation. So that brings us to kind of what I'm doing beyond that, which is pharmacology management of their increased intracranial pressure. Salia, walk us through like salty or sweet or hypertonic saline, mannitol. Which am I giving, and in what situations, and what should I be looking for as I give those drugs?
Yeah, excellent question. I get this every single time, sweet or salty. So the truth is, whatever you have available and is fastest for you in your institution, I think that's the answer. But I think it can walk us through, okay, what to consider, what is usually actually faster, what is usually more available. So, when we talk about sweet, we talk about mannitol, which is an hyperosmolar agent, and we talk about salty, we're talking about hypertonic saline. Really, it goes from 3% to 23.4%. Let's talk about maybe mannitol first, and then we talk about hypertonic saline. So one of the things that is nice about mannitol is that it can be given peripheral. So again, if your patient does not have a central line and you don't want to waste time giving or putting in a central line, then that is awesome. Mannitol dosing is usually 0.5 to 2 grams per kilogram. I can tell you that because it's such an acute situation, when they ask me, I usually talk about 50 to 100 grams to make it kind of easy. Some institutions have the vials. Some institutions have the infusion bags. Again, it doesn't matter what concentration you have, the 20% infusion bags or the 25% vials. The idea is that you give 50 to 100 grams. That's usually sufficient for most patients. And then, although you do not need a central line, you always need a filter. Sometimes I get questions about, this is an emergency, can I give it without a filter? Absolutely not. You need a filter because of crystallization. Sometimes you don't see these crystals and you don't want to obviously infuse crystals. Now, what do we monitor for? Remember that mannitol actually can cause hypotension. It can make people diurese. It's something that, again, like we know about emergencies and all that, but we try not to use mannitol in patients with renal failure just because of the risk of accumulation and the fact that it can cause rebound ICP issues if it accumulates in the body. You want to repeat the doses, the 1 gram per kilogram. You could repeat that based on your ICP. if you wanted to kind of get a sense of how much more you could repeat mannitol, you can always look at your osmolar gap. Osmolar gap of 20 is the threshold. So if your osmolar gap is less than 20, that means that you have room to give more mannitol. So that's, all about mannitol, which I think a lot of institutions are comfortable with giving it. It is, pretty available. It can be given through a peripheral line and all of that. I think hypertonic saline is unique in a sense that not only it helps, with the ICP crisis, but if your patient requires sodium augmentation, that's the beauty of this agent. Again, the 23.4% I think is the agent of choice if you are dealing with acute emergencies. Again, if you're bumping to sodium or if you don't have that concentration, you can definitely give the 3%. We talk about giving 500 mLs of the 3% over 30 minutes as a bolus until you have more access. The 3%, remember, can be actually given peripherally. Now, if you have enough studies to say that the 3% is actually safe, peripheral administration is safe. But then the 23.4%, although there are some reports talking about its administration peripherally, I have to say that we have not changed our practice yet. We're still very much so talking about giving it centrally only because of the risk of extravasation. It's very, very hyperosmolar. Now, if you don't have a central line, you can actually, traditional central line, you can give it as IO. As far as the dosing, we talked about how with the 3%, we talk about 500 ml boluses, which can get your sodium up. But if you wanted to use the 23.4%, it's the 30 ml, which is the usual dosing. Again, I think back in the day, we used to give it via a longer administration time of 15 to 20 minutes. Now we know that it can be given faster. So now we're doing it as an IV push. The risks are that you have to have the appropriate line, and also hypotension can happen. So again, making sure that you are hemodynamically monitoring your patient, making sure that you are supporting the blood pressure with vasoactive agents if you have to. Obviously, sodium check should be done after that. We talk about every 4 to 6 hours of checking sodium to make sure that we're not losing track of how much we're giving, and we're not ending up with super, super high sodium numbers.
That's such awesome advice. I think one of the things that a pearl that I've learned is almost everyone, I think actually everyone has code CART bicarb. And so if you are practicing in a place where you can't actually get mannitol or 3%, a little good pearl is that the code CART bicarb actually has about 50 milliequivalents in salt of sodium. So pushing 2 of those is roughly equal to about 200 cc's of that 3% saline. So nice little pearl if you're practicing somewhere where you don't have access to some of these other traditional hyperosmolar agents. And so we've given this treatment, whether you're giving the hypertonic saline or mannitol, get one of them in, just as Sally was saying, like whichever one is faster that you can get, give that. The thing then that you have to kind of decide, I think, in sort of this trajectory of your sick patient, is this a patient who's going to benefit from invasive neuromonitoring, or do we have to estimate what their ICP is based on sort of non-invasive monitors? The guidance for who gets invasive neuromonitoring is all based on the TBI guidelines. The recommendation is for a traumatic brain injury if a patient is in a coma, so a GCS of 3 to 8, and has an abnormal scan, or if they're in a coma with a normal scan but have some concerning features like motor posturing, or they're hypotensive, or they're older than 40, then it's appropriate to use invasive monitoring in that situation. Some of our other patients may get an EVD because they have a concurrent hydrocephalus issue. So a lot of our ICHs will also have IVH, and they get an EVD placed for drainage of that IVH. Same thing with our subarach patients. Frequently, they will have EVDs. And those are really nice because they actually give us a number, right? We can go by that. For other patients in the unit, especially those with the global problems that are not trauma patients, we're really using non-invasive monitors, and that can include, just the non-con PET CTs that we're getting. It can include pupillometry. optic nerve sheath diameter, and even the pulsatility index from our transcranial Dopplers. So there are a lot of ways that we can sort of estimate if a patient's ICP is up or not. And you either still have concern for increased ICP, or you actually have a number that's showing you that you do have increased ICP. Then we have to get into higher tiers of ICP management. That could include mildly hypoventilating the patient. Again, we don't want to get sort of below a PaCO2 of 32, but sort of in that mild range, that's okay. I tend to think about real hyperventilation only for the patients who are like on their way to the OR as a temporizing measure. Neuromuscular paralysis also has the ability to be efficacious in lowering ICP. I usually try that first. I actually give a bolus and see, like, did that help the patient? And only commit patients if it actually was helping them. And then we have to really assess where patients are on sort of their cerebral autoregulation curve. And that's a little bit tricky, so we're not going to get too deep in the weeds on that. Beyond those interventions, then we're really looking at a little bit of cooling, so mild hypothermia, 35 to 36 degrees, and then surgical interventions. If the patient's not a surgical candidate for a decompressive hemicraniectomy, then really I think kind of the sort of last line medical treatment we have is a barbiturate coma. And so, Salia, walk us through, if you actually do get there, what are some of the things that you have to keep in mind? This is kind of a high risk medication. So what should we know?
Yeah, exactly. As you mentioned, Casey, this is really, I think, the last resort. I think this is when you get here, you've really done everything else. You've exhausted all the other options. Really, the way this works out, at least from my experience, is that, we have people on propofol initially, but then, as you know, there's a lot of issues with propofol when you give it at such a high dose for ICP crisis that we know that it's not sustainable because of the propofol-related infusion syndrome complications and risk of cardiac arrhythmias, really, which is really ultimately gets people into trouble with the propofol-related infusion syndrome. So when we talk about pentabarb, number one is that there should be a discussion with the family, because this is an agent that is going to mask your neuro exam very much significantly for days. One piece of clarification is that your pupil exam will still be unchanged. So that's really the only exam that you have in that setting. Everything else will probably be gone. And the idea is that if you ever wanted to reconsider or have a family meeting, you have to do that before putting someone on pentabarb, because again, because of the half-life, the drug will be in the system for days. So you always want to have that discussion with the family before you put them on the pentabarb coma. Now, just like what we talked about with hemodynamics, this one is huge, right? This is a huge negative inotrope and can cause significant hypotension, bradycardia. Almost always these patients end up on vasoactive agents. I usually, when I see people reaching for pentabarb and wanting to start that, I get the Nora-P infusion from our Pyxis machine before even they start a pentabarb, because I know that it's going to be needed, especially with the boluses that we give. You basically have to also think about how to monitor, your management. Sending pentabarb levels really has not been shown to be very effective. We look at clinical signs, we look at ICP crisis, and then also EEG. A lot of these patients are hooked to EEG, so burst suppression is typically what we think about when we have people on pentabarb for treating these complications. There's all the other side effects, we commonly talk about with all the barbiturates. People end up usually with ileus, which is really complicated. And, I've had people with bowel ischemia. It's a common side effect, unfortunately, and happens a lot, but it's a price that sometimes we feel like we have to pay if we can get people over this hump. And then the other piece is that when do you send for levels, right? I think when you are done with your pentabarb coma, and you're still not getting an exam from your patient, I think that's when we think about, okay, let's send pentabarb levels to see if this is because of the brain damage, or this is because of pentabarb still lingering in the system. Obviously, drug-drug interactions, remember that barbiturates are all a CYP inducer, so if you suspect significant interactions, something to keep in mind. So those are some of the pearls, I would say, with pentobarb. Again, a lot of discussions to have with the family, with the team, making sure they know about the side effects, making sure that they're protected hemodynamically, they're intubated. We talk about eye care for these people also to make sure that, their eyes are moist and because they're going to be closed, and just making sure they're comfortable. And then again, not sending levels while they're on it, but rather looking at the EEG for burst suppression.
So I think that's pretty much our algorithm, starting from just walking in the door, making sure their positioning is optimized, that they're not hypoventilated, and then looking to the sort of, the foundation of this management, which is our hyperosmolar, and then graduating into some of these more extremes like paralyzed sedating, cooling, and then this pentobarb coma. I think with that, we can wrap it up. Salia, any last pearls to leave people with?
I think the most important thing is that what do you have available in your institution? Use that first as far as hyperosmolar agents, hypertonic saline versus mannitol. As far as which one's more effective, we don't really know. I mean, right now, there's no evidence to say one is better than the other. I think just having access and knowing the dosing and knowing the side effects. And then if you need to escalate to pentobarb, just knowing the side effects and how to monitor and how to titrate. Those are some of the pearls that I hope that this talk gave you and helped you with your future management.
All right. Until next time, guys. Thanks so much. Bye.
Thank you. Bye, guys.